malignant diseases and some benign diseases, which will most likely be covered in your CERES or RIT examination. So here are my references. So it's the ASCRS textbook, which is actually being used by colorectal surgeons, the clinical practice guidelines from the latest ASCRS, NCCN guidelines for cancers, and the following journal for fistula. So we have a vast range of topics for colon, rectum, and anus, but the following, which I highlighted, will be covered in our lecture. So first is colorectal cancer screening. So for colorectal cancer screening, so for average risk, here is the indications for colorectal cancer screening. So it is for patients 45 to 75 years old, in which we have a life expectancy of more than 10 years. However, for those who are 76 to 85 years, it should be individualized, weighing the risks and the benefits of these patients, including their comorbidity status and estimated life expectancy. So for patients less than 45 years, we need to know when to do risk assessment. So for this patient, since around 50%, actually half of the patients presenting with early onset colorectal cancer or less than 45 years, we should note the presence of alarm symptoms. This includes rectal bleeding, iron deficiency anemia, abdominal pain, or weight loss. And rectal bleeding attributed to hemorrhoids that do not resolve with treatment should be also indicates evaluation. So prompt evaluation should be done regardless of age. So for patients with positive family history, so this should meet the following criteria. For patients with one or more first-degree relative with colorectal cancer at any age, colonoscopy should begin at the age 40 years old or 10 years before the earliest diagnosis of colorectal cancer. However, if patients have second or third degree, this follows the regular screening for average risk patients, which is at 45 years. While for those with first degree relative with confirmed advanced adenomas, colonoscopy should begin at age 40 or at the age of onset of adenoma of the relative. And here are the different screening modality and schedule based on NCCN. And the benefits and the cons of different screening modalities based on Schwartz. So first we'll discuss on colon cancer. So for colon cancer, here is the guidelines for malignant polyp. So if we have a pedunculated or sessile polyp or adenoma with invasive cancer, first we need to do biopsy or pathological review. This should be done through colonoscopy. And if we did colonoscopy or fiber sigmoidoscopy, it is good to do tattooing or marking of the polyp site for eventual surgery. And it is now included in the guidelines to do MMR or mismatch repair or microsatellite instability testing. So for malignant polyp, there is the question if we should do endoscopic excision versus oncologic resection. So this depends on the adequacy of the polypectomy of excision margin, the depth of the submucosal invasion of cancer cells, the degree of the cellular differentiation, the presence of lymphovascular or perineural invasion, and the amount of tumor budding. So for pedunculated polyps, this is classified according to Haggett's classification. So level 1 is if it involves the head, level 2 if it involves the neck, level 3 if it involves the stomach, and level 4 if it involves the base of the submucosa. So the importance of the Haggett classification is that for Haggett 1 to 3, it has a very low risk of lymph node metastasis. However, if it involves level 4 or the submucosa, it has a high risk for lymph node metastasis around 25 to 30%. While Kikuchi classification is being used for sessile polyp. So Kikuchi classification for sessile polyp, it is divided into 3, SM1, SM2, and SM3. So it involves 1/3 of the submucosa. It is SM1, SM2 for 2/3, and SM3 for 1/3. However, if you talk to pathologists, they actually do not use the one third, two third, or lower third, they actually use the measurement of the depth of invasion. So Kita-JAMA, so according to Kita-JAMA, this shows that for pedunculated polyps with Haget level 1 or Haget level 2 or 3 or SMI less than 3 millimeters, there's a very low risk of lymph node metastasis. However, for non-pedunculated or sessile polyps, the risk of lymph node spread increases with increase of submucosal invasion. So for if it is less than 2 millimeters, it is 3.9%, but if it is more than 2 millimeters, it increases to 17%. So patients who are potential candidates for endoscopic resection are those without features of deep submucosal invasion. So these are patients with superficial submucosal invasion with favorable histologic characteristics. While on-block endoscopic resection is mandatory for endoscopic resection. So this helps us accurately assess the depth of the submucosal invasion. And if the especially for those with unreliable resection margin, if the tumor area, the polyp is fragmented or piecemeal resection. So for those less than 2 cm or 2 cm or less, endoscopic mucosal resection is being done, while 2 cm or more than 2 cm is endoscopic submucosal dissection. So these are usually done by advanced endoscopist or by GI. For endoscopic features suggestive of deep submucosal invasion includes the following: depressed lesions, presence of ulceration and excavation, and abnormal pitting or vascular pattern. So in these types of polyps, biopsies should be done because these are usually features suggestive of malignancy or deeper involvement of malignancy. And in these types, surgical resection is recommended. So for malignant polyp, this is the recommendation for endoscopically remove malignant polyp according to NCCN. So unfavorable features are those that are high grade, involvement of the lymphovascular invasion, positive margin, and presence of tumor budding. While fragmented specimen or unfavorable is also part of unfavorable feature, and presence of hadith or a submucosal invasion of more than 1 mm is an unfavorable feature. But for favorable are low grade, no lymphovascular invasion, negative margins, low to immediate tumor budding, the specimen is completely removed as whole, Haji 2123, and less than 1 millimeter submucosal invasion. So the importance of this is that if there's unfavorable features, you can do colectomy, while observation is done for favorable features. So for colon cancer, we say that there is a positive resection margin if there's the presence of invasive adenocarcinoma, 1 mm or less from the excision margin, while negative margins is if it is uninvolved with adenocarcinoma on the margins. And here is the NCCN guidelines again for pedunculated or sessile polyps. So if the polyp is removed completely with favorable features, you can do observation for pedunculated polyp, especially for Hagia 23. But for sessile polyp with invasive cancer, observation may be done, but a colectomy is another option. So in this type of polyp, for sessile polyps, they have greater incidence of adverse outcomes where including residual diseases, recurrent diseases, mortality, and hematogenous metastasis, but not lymph node metastasis. So configuration by itself is not a significant variable for adverse outcomes. Endoscopically removed sessile polyps with grade 1 or 2 histology, negative margins, or no LVI can be done with endoscopic polypectomy such as EMR or EST. And here's a workup for colon cancer based on NCCN. So for colon cancer that is appropriate for resection or which is non-metastatic, we need to do MMR and MSI testing, and included newly in the guidelines is the PIK3CA testing. So this is important because for this patient they give aspirin, which improves their overall survival. Well, for metastatic cancer, it is needed to do molecular testing including KRAS, NRAS, BRAF, after to MMR, MSI testing, and NGS panel. So for Lynch syndrome, here is the routine tumor testing recommended according to NCCN guidelines. So for those identified pre-surgically, it is important to do this because we can determine if we can do some subtotal or segmental resection. And this allows the patients, for those with rectal cancer, if we can do neoadjuvant treatment or if they respond, non-operative treatment. While those Lynch syndrome identified post-surgically, after surgery, it is the cons of this is that do we can't do adequate surgical decision making since it has already been resected. And here is the testing for Lynch syndrome according to NCCN. So for those with known Lynch syndrome in the family without documented MMR deficiency, here is the guidelines. So I think we know this. And those with documented MMR deficiency, with a personal history of colorectal cancer, endometrial cancer, with MMR deficiency, we can do next-gen sequencing or PCR. So for Lynch syndrome, we all know the Amsterdam criteria. So it helps us identify the potential affected individuals, while the revised the test the criteria is important to know who will benefit from additional workup with genetic testing. Again, for Lynch syndrome, for those who are on surveillance have adenocarcinoma in the colon, an option can be to do a segmental or extended colectomy. However, if you do segmental, it is important that this patient should have active surveillance after because of the possible presence of another metaphorous tumor. While for those with rectal adenocarcinoma, you can do proctectomy or total proctocolectomy. So again, if you do proctectomy, aggressive surveillance is important. So for colon cancer, a histologic confirmation of the adenocarcinoma should be established when feasible, and the entire colorectal mucosa should be evaluated for synchronous pathology. So a colonoscopy is the preferred evaluation method. And for those with adenomas, they usually have synchronous adenomas present in 30 to 50% of patients, while for those with colon cancers, synchronous cancers may be present in 4% of patients with stage 1 to 3 sporadic colon cancer. And synchronous colon cancer may be treated by two segmental resections or a subtotal colectomy. So for patients with endoscopically obstructing distal colon cancer, such as in the sigmoid, here are the options. So for endoscopically obstructing distal colon cancer in the distal sigmoid, at the bottom of the slide, evaluation of the proximal colon can be done through CT colonography, intraoculonoscopy, post-colonoscopy, or PET scan. However, for obstructing proximal cancer, such as in the ascending colon, we don't need to examine the more proximal colon, and we can just do it by surgical resection. So here's the guidelines for colon cancer with proficient MMR or microsatellite stable, which is non-metastatic based on NCCN. So for those tumors that are resectable and non-obstructing, we can proceed right away with colectomy or surgery with inclusion of the regional lymph nodes. For those that are resectable, however obstructing, we can do one-stage colectomy with removal of the lymph nodes, resection with diversion, or we can divert first and do colectomy as a stage procedure, or stent and colectomy as a stage procedure. For tumors that are T4B or bulky, in the guidelines, they now recommend considering neoadjuvant chemotherapy before doing colectomy. While those that are locally unresectable or medically inoperable, we can do RT, IMRT with infusional 5-FU prior to reevaluating until the tumor is resectable. So as I said earlier, so a PIK3CA mutation testing can be done so that if if it is positive, you can give aspirin for 3 years as this improves the patient's overall survival. So, post surgery, if the tumor is T1 to T2 or stage 1, we can do observation. T3 and 0 without high risk features, observation is still preferred. While those with high risk features or T4 and 0, chemotherapy with capecitabine or 5-FU for 6 months may be done. So for stage 2, so for T3 and 0 with high risk features or T4 and 0, chemotherapy with capecitabine, 5-FU, or FOLFOX or KPOX, observation may be another option. So high-risk features include the following. For clinical, this is bowel obstruction or localized perforation. Pathology includes less than 12 lymph nodes obtained during the surgery, presence of a poorly differentiated or undifferentiated tumor, presence of LVI, PNI, the positive margins or indeterminate margins, presence of tumor boarding. So these are features that are present that in patients with higher risk for recurrence. For stage 3 tumors, such as those with node positive, so these patients would benefit with chemotherapy such as KPOX and FOLFOX. So when neoadjuvant therapy is not included in the treatment plan, a curative intent colectomy should be performed without unneeded delay. So surgical delays for up to 2 weeks are not detrimental to the disease-free or overall survival according to the guidelines. And the extent of resection for colon cancer should respond to the lymphovascular drainage of the colon cancer. So for margins, we need to have 5 to 7 cm, proximal and distal margins. And for lymph nodes, we need at least 12 lymph nodes. So now for colon cancer with deficient MMR or MSI high, which are non-metastatic, here is the guidelines from NCCN. So again, it is the same for proficient MMR or MSS. So for resectable, you can proceed right away with surgery. For those that are obstructing, we can do colectomy or stage procedure with diversion. While for clinical P4B or bulky nodal disease, the difference in MSI high or deficient MMR is that instead of giving chemotherapy, we can give immunotherapy. So these patients they respond well actually to immunotherapy. However, if immunotherapy is not available, we can give FOLFOX or KPOX. So those that are locally unresectable or medically inoperable, again, immunotherapy is the preferred treatment. But if it's not available or a patient is not candidate for immunotherapy, we can consider RT with infusional 5-FU, evaluate for response, and do surgery with intra-op RT. So immunotherapy includes the following: nivolumab, pembrolizumab, and the others. So what's available locally is pembrolizumab. Again, for these patients, PIK3CA mutation, testing may be done to see if they benefit with aspirin treatment. So in these patients with dMMR, MSI high colon cancer, for stage 0, stage 1, and stage 2A and B, they benefit with observation only. So if you would compare it with proficient MMR, it's only stage 1 that benefit with observation. And for stage 4B, in these patients, observation may still be done, but you can consider giving chemotherapy for low-risk stage 3 disease. While presence of lymph node metastasis or stage 3 disease, in these patients, they would benefit from chemotherapy with KPOX or FOLFOX. And here is the surveillance for colon cancer depending on stage. So for stage 1 in these patients, they need to undergo colonoscopy a year after. If there's the presence of advanced adenoma, repeat it in 1 year. If there's none, you can repeat in 3 and 5 years. So as you can see here, there is no CEA in stage 1 for monitoring. For stage 2 and 3 and stage 4, here is the following, and here is the summary and table. So for stage 2 and 3 and 4, they have the same interval for history and PE every 3 to 6 months for the first 2 years, every 6 months after the third year onwards, also for CEA. However, for CT scan, chest and abdomen with pelvic, for stage 2 and 3, it is done every 6 to 12 months for the 5 year duration. But for stage 4, the first 2 years is more intense, every 3 to 6 months, and after the third year onwards, it's 6 to 12 months. Colonoscopy is the same for all stages. It's colonoscopy in the first year, and if there's advanced adenoma, you can repeat it in 1 year. If there is none, repeat it in the third and fifth year. However, if the patient has no preoperative colonoscopy, we can repeat the colonoscopy in 3 to 6 months, especially in those obstructed lesions, because we need to know if there is the presence of a synchronous tumor in the proximal colon, while PET scan is not indicated in the guidelines. ctDNA, I think you've all heard about it. So this has been present for like the last 5 years or 3 years or so. However, this is a prognostic marker like CEA. However, there is still insufficient evidence to recommend routine use of ctDNA outside clinical trials. So it is still not recommended for surveillance. So around 20% of colon cancers are actually emergency, such as bleeding, perforation, and obstruction. So in these types of patients, we need to do surgery to avert the immediate negative impact of complication, achieve the best possible tumor control, and ensure timely recovery to permit initiation of appropriate systemic treatment if they need chemotherapy. So for obstructing colon cancers with curable disease, for example, in the left-sided cancer, you can do endoscopic stent decompression. However, the stent should not involve around 7 cm or below from the anal verge. We can do diverticulostomy with interval colectomy. We can do initial oncologic segmental colectomy. While for right-sided and transverse cancer, transverse colon, we can do initial oncologic segmental colectomy, or we can also do stent decompression with subsequent interval colectomy. For those with tumor perforation, we can do initial oncologic segmental colectomy and consider anastomosis in patients if there is minimal contamination, the tissues are healthy, and the patient is stable in intraop. While those with perforation of the uninvolved colon proximal to the obstructing tumor. So for the tumor, we need to do oncologic segmental colectomy. While the perforated part, we can do repair or resection with or without diversion or perforation of the segment. So again, it depends if there is raw spillage, the patient is stable. So it depends if you can do diversion or you can do repair or resection. While for acute lower GI bleeding, they are initially managed with non-surgical approaches such as CT angio, colonoscopy, conventional angiography, radionuclide imaging for preoperative localization. And here is the workup for colon cancer. So above is for those that are appropriate for resection, which is non-metastatic. And again, the one below is for metastatic colon cancer. So for metastatic colon cancer, I said earlier that molecular testing is included. And in these types of cancer, PET scan may be done, but it is still individualized. So for metastatic colon cancer with pMMR or microsatellite stable, for those with synchronous liver only or lung only metastasis that are resectable. So there are different options. The preferred one is to do synchronous or stage colectomy with liver or lung resection or local therapy. Another option is to do neoadjuvant treatment prior to doing synchronous or stage colectomy. Another option is to do colectomy followed by chemotherapy and followed by stage resection of the metastasis. So here it is. So based on the NCCN guidelines, For small solitary metastases in the periphery of the liver or the lung, these are the ones that are lowest risk for surgical morbidity and mortality. So in these patients who are healthy with colon resection appear straightforward, these patients are good candidates for a upfront resection, which is followed by adjuvant chemotherapy. For those with more than four liver metastases with asymptomatic primary, an appropriate candidate these patients are appropriate candidate to start with neoadjuvant chemotherapy. Assuming that the patient is fit for surgery and the liver lesions respond or at least fail to progress to neoadjuvant treatment, they may be candidate for simultaneous liver and colon resection followed by 3 months of additional adjuvant chemotherapy. While those with a setting of potential impending obstruction of the colon with borderline resectable hepatic metastasis, they would benefit from upfront colon resection and 2 to 3 months of chemotherapy and reevaluate for resectability of the metastasis. Another option for obstruction is doing an alternatively an endoscopic stent. Then, to alleviate obstruction, we can then proceed with chemotherapy in these patients earlier than if you do diversion or resection, and again reevaluate for resectability of the metastasis. So for DMMR or MSI high metastatic lesions, for those that are resectable, liver and lung only metastasis, you can do synchronous or stage resection of the metastasis. However, another option which is preferred is actually the neoadjuvant treatment by immunotherapy. So after that, if it depends on the reassessment, we can do synchronous resection or stage resection. Next is on rectal cancer. So my reference on this is the NCCN guidelines. So rectal cancer is divided. The rectum is divided into three. So we have the low, mid, and high. So on based on the ASCRS from the US, here is the division of the upper, mid, and lower rectum, and the Europe or ESMO here is their division. So as you can see, for Americans, higher their upper is higher, it's 12 to 15, while Europe is lower at 10 to 15 cm. But we actually more use we adapt it on Filipinos since we have lower height compared to the Western. So for lower, it's 3 to 5, mid 5 to 10, upper 10 to 15. So rectum is a portion of the bowel located below the pelvic inlet. So you do create an imaginary line from the sigmoid promontory to the top of the pubic symphysis, and this is where your rectum starts based on imaging. So the one on the higher rectum has a peritone is actually free. It is involves the peritoneal cavity. The mid rectum has a part of the peritoneal cavity which is in the peritoneal reflection, where the lower rectum doesn't have any part of the peritoneum, and it is actually extraperitoneal and involves only the mesorectal fascia. So here is the guidelines for rectal cancer based on NCCN. So again, for polyps, sorry. So for single polyp with favorable features, you can observe for pedunculated polyp, but for C-cell polyp, you can do endoscopic ultrasound or pelvic MRI for us to know if you can do observation or proceed with surgery or transanal excision. While those with fragmented specimen with unfavorable features, we can work them up for rectal cancer, do MRI, endoanal ultrasound if it is available for us to differentiate a T1 or T2 lesion, and depends on the workup if you can do transanal excision or proceed right away with surgery. So the rectal cancer protocol pelvic MRI is the preferred imaging, while an endorectal ultrasound can be done to differentiate between T1 or T2 tumors, or when MRI is contraindicated, such as patients with pacemaker that is contraindicated for MRI or with metals. So pelvic MRI rectal cancer protocol includes the following: the depth of the tumor penetration, presence of lymph node metastasis, the relationship of the lesion or the tumor within the mesorectum and the mesorectal fascia, the status of the CRM if it is positive, such as presence within 1 millimeter from the circumferential resection margin. So high-risk features can also be seen in MRI, such as T4 status, extramural vascular invasion, CRM within 1 mm, and the presence of extramural tumor depth at least 5 millimeters. An endorectal ultrasound helps differentiate T1 versus T2 tumors, and this is done if MRI is contraindicated. However, disadvantage are the following: it is operator dependent, it is limited for bulky tumors, it is quite uncomfortable, and there is inability to evaluate stenotic lesions that precludes passage of the transducer. So this is how the rectal ultrasound is on the right side, and it is subdivided depending on the involvement of the different layers of the rectum. So here it is based on T1 staging and T staging. And here is how it looks like on actual endorectal ultrasound. So as you can see if there is involvement of a certain layer. So on the right, it is T3. So transanal local excision is being done, and it should meet the following criteria on the right. So I will not read it one by one. So full thickness excision should be done in transanal local excision with at least 1 centimeter closely normal circumferential margin, and the depth should be down to the perirectal fat. So you should be able to see fat when you do dissection or transanal local excision with a minimum of 2 millimeter deep margin. Other options include transanal endoscopic microsurgery and transanal minimally invasive surgery for local excision of more proximal lesions in the rectum. However, it depends on the availability and expertise. So here are the different features that should be determined when doing transanal local excision. So favorable features include less than 3 cm in size, T1, grade 1 or 2 or low risk tumors, low grade tumors, no lymphovascular invasion, negative margins, Hadget's 1 to 3, SM1 or 2, or less than 1 millimeter submucosal invasion. While unfavorable features are the following on the right. So for those with favorable features, you can do observation, while for unfavorable features, you can proceed right away with rectal resection. And here are the workups for rectal cancer. The one on top is for those that are resectable with no proven distant metastasis, and the ones below are the one with metastasis. So again, MMR MSI testing and PIK3CA testing are done for stage are for these tumors that are non-metastatic. Consider proctoscopy, if MRI and the rectal ultrasound. If you're going to do stoma, endostomal therapist should be done with pre-op site marking, and multidisciplinary team evaluation is important actually. And for female patients, fertility risk discussion counseling is important. And for those with metastasis, molecular testing such as BRAF, KRAS, HER2, MMR, MSI status should be done. And again, here are the different diagnostic workups based on the following: location, visualization of the colon, the workups that should be done for rectal cancer. So here is the guidelines for rectal cancer without suspected or distant metastasis. So for T1, for those that are non-surgical candidate, we can actually refer them to GI and do endoscopic submucosal dissection. And those that are surgical candidate, besides ESD, we can do transanal local excision if the tumor is accessible to transanal local excision. And in these patients, we can do MRI or endoanal ultrasound. So after doing transanal local excision for T1 tumor, if it is indeed T1 without high-risk features, we can do observation. While those with T1 with high-risk features or those that are T2, high-risk features include positive margins, LVI, poorly differentiated tumors, or invasion of more than 1 millimeter of the submucosal invasion. A transabdominal resection such as LAR or APR should be done. Another option actually in this patients not amenable for surgery or not fit for surgery is doing chemo-RT or long-course chemo-RT followed possibly with chemotherapy and do staging. For T1 or 2 tumors, T1 to 2 tumors, you can do transabdominal resection. And this should be based on pelvic MRI or the rectal ultrasound. Transabdominal resection. Or in these patients who are not a candidate yet for surgery, chemo-RT first, followed by possible with chemotherapy, we stage and do surgery after. Another option is anal local resection for selected patients. So this is a viable option for patients who have strong but incomplete response and are unable or unwilling to undergo the regular standard TME surgery. The most suitable candidate are those patients who have a near complete response after undergoing chemo-RT. And for patients with clinical complete response, another option for the patients is to do surveillance, such as watch and wait. While for T3 tumors and 0 low risk in the high rectum, so we actually treat these patients as colon. So meaning these are tumors that's 11 to 15 cm from anal verge. So we can proceed right away with surgery. And after we do anal resection for T1 to T2 tumors, here are the following treatment options. For T1 to 2 and 0 M0, we can observe these patients after surgery. Those T3 and 0 M0 can proceed right away with TNT or total neoadjuvant therapy. So there is consolidation chemotherapy, meaning chemo-RT first, followed by chemotherapy, or induction chemotherapy, meaning chemotherapy first, followed by chemo-RT. So again, for T3 and 0 upper rectal tumor or 11 to 15 cm from anal verge, observation may be done. Or for tumors with well to moderately differentiated, veins less than 2 millimeter in the mesorectum, and negative for PNI and LVI, observation may be an option for these patients. While T4 and 0 or the presence of lymph nodes post-surgery, these are candidates for TNT. So again, consolidation chemotherapy or induction chemotherapy may be done. Adjuvant chemotherapy may be an option only for T1 to 3 and 1 only patients. And again, for high rectal tumors, T3 and any regardless of location, we treat them as colon so we can proceed right away with surgery, but we still need to determine their MMR and MSI status. So for tumors, PMMR, microsatellite stable, which are non-metastatic with the following T-staging, T3 and any presence of any lymph nodes, N1 to N2, or T4 and any, or locally unresectable. Here are the following treatment options in these patients. So, for example, you did an MRI, and these are the reading on MRI on the T and N staging. So, in these patients, we can do total neoadjuvant therapy, meaning we can first do chemo-RT, followed by consolidation chemotherapy for 12 to 16 weeks, and do restaging 4 weeks post-chemotherapy. Short course RT is an option. So this is the Rapido trial. So these are indicated for T4A, T4B, AMVI, N2, or positive mesorectal fascia on large lymph node. However, the latest results from the Rapido trial on their 5-year follow-up showed a higher local recurrence rate on PET with 10%. So actually, Rapido is not much recommended as of the moment. Another option is induction chemotherapy, meaning we do chemotherapy first, followed by chemo-RT, and do restaging 8 weeks post-RT. And another option, the third option, is the prospect trial in which we do chemotherapy for non-T4 lesions to do sphincter saving surgery after. So after completing the chemotherapy regimen, we restage them. And if there is tumor regression more than 20%, we can proceed right away with surgery. So pwede nang hindi ma-RT yung patient. But if there is tumor regression less than 20% or the presence of high-risk features, we can still proceed with chemo RT after chemotherapy before proceeding with surgery. So this is important because the prospect trial, actually RT, those patients who undergo RT is very detrimental in the type of the difficulty of the surgery. So again, for those who undergo TNT, such as this one, after doing restaging, another option besides surgery in patients who respond with, especially those with clinical complete response, or meaning the tumor has completely shrunk after imaging or MRI, we can do a watch and wait protocol. So in these patients, they have no residual disease based on the following: DRE, MRI, and endoscopic such as colonoscopy or flexible sigmoidoscopy. So non-operative approach may be considered in these patients. However, the patient should be informed that with non-operative approach, they have they have to follow a very strict surveillance protocol. So here's the different findings to determine on DRE, flexible sigmoidoscopy, and MRI if the tumor has complete clinical response or near complete clinical response. And here is the surveillance protocol for those patients who would opt to undergo watch and wait or non-operative treatment. So as you can see, besides history and PE and CEA, more frequently you would see the patients for DRE and flexible sigmoidoscopy for the first 2 years for 3 to 4 months. You do MRI every 6 months for the first 3 years. So and after that, it is important to do the MRI and MRI every 6 months for at least 3 years because this is the time which there is high recurrence of the tumor even after clinical complete response. And next is the management for DMMR or MSI high tumors, which are non-metastatic. So again, MSI high tumors are the ones that are responsive to immunotherapy. So in this patient, the preferred treatment is immunotherapy such as dostarlimab, nivolumab, and pembrolizumab. Again, pembrolizumab is the one that's available locally. And I think if you've heard in 2022 or 2023, they found a immunotherapy drug with 100% response, and that is dostarlimab. So in their study, the latest study that they released, I think around 20 patients had 100% response, clinical complete response after giving immunotherapy. So in these patients, you do evaluate every 2 to 3 months. And if there's clinical complete response, again, you do the watch and wait protocol surveillance. However, if there's persistent disease, you give adjuvant, you give chemo RT, and if there is no response, you can proceed right away with surgery. But if there is clinical complete response or near complete response, you can proceed with watch and wait protocol. And here is the surveillance following surgery for rectal cancer. So for low-risk polyps, you can do proctoscopy every 3 to 6 months for 2 years, colonoscopy after 1 year. For those who undergo transanal excision, proctoscopy with endoanal ultrasound or MRI more frequent in the first 2 years, then every 6 months for the next 3 years, and colonoscopy as usual after 1, 3, and 5 years. For stage 1 with full clinical staging, you can just do colonoscopy. And for stage 2 and 4, it is the same as usual for your colon cancer. So here is a summary for stage 2, 3, and 4 in a table format. So again, PET scan is still not indicated in these patients. So for rectal cancer in the upper rectum, we do anterior resection with wide mesorectal excision. So we call it wide mesorectal or tumor-specific mesorectal excision, and we need to have at least 5 cm margin distal to the margin of the tumor. So it is important. While for those in the mid or low rectal cancer that's amenable or without involvement of the sphincter, we can do low anterior resection with total mesorectal excision with or without proximal reversion. So a total mesorectal excision should be done as part of an ultra low anterior section or APR. So a at least 1 to 2 cm margin distal from the tumor is important. And we need also to know the status of the circumferential resection margin. So the circumferential resection margin ideally should be negative, or no tumor should be present within 1 mm for the from the mesorectal fascia. Because if it is positive, you most likely have a positive circumferential margin or positive tumor during dissection. While for low rectal tumor with involvement of the sphincters, we can do APR with total mesorectal excision. So APR is mandatory if there's, again, involvement of the sphincter elevator muscle, loss of integrity of the intersphincteric plane, margin negative resection of the tumor would result in unacceptable sphincter function. And when doing LAR, assessment of anastomotic integrity should be done through leak testing, endoscopic examination, or microperfusion evaluation by ICG. You can also do that. Intra-op correction can be done by suture repair if the leak is very small, but if there is a big leak, we can take down the anastomosis, do reconstruction with diversion. So for lymph node dissection, so for rectal tumors, if for us to know if we do lateral pelvic node dissection, the cutoff size is for pre-neoadjuvant treatment is more than 7 millimeters, and the cutoff for post-neoadjuvant treatment is more than 5 millimeters. So next topic is on rectal prolapse. So rectal prolapse is the circumferential full thickness protrusion of the rectum through the anus. So internal prolapse is when there is just the rectal wall that intercepts but does not protrude outside. But mucosal prolapse is a partial thickness protrusion of the mucosa associated with hemorrhoidal disease. So here are the different approaches for rectal prolapse. So we can do abdominal surgeries and perineal surgery. So I will be discussing them roughly one by one later. So for non-operative management, these are patients that cannot be corrected or that are not candidate for operative management. So we can do fiber as stool softener or give table sugar to reduce the edema of the protrusion or the prolapse. For operative management, rectopexy or fixation of the rectum is a key component of the abdominal approach. Sigmoid resection with posterior rectopexy for patients with constipation. So we need to do resection in patients with constipation. We need to do the revision of the lateral stalks. So this may worsen post-op constipation but decreases the recurrence rate in rectal prolapse. For trans-abdominal repair, there are multiple options. First is the anterior rectopexy. However, for anterior rectopexy or mobilization with fixation to the anterior abdominal wall, it has a high complication rate. For posterior rectopexy, meaning mobilization and fixation of the rectum to the sacral promontory, this actually has a good low recurrence rate. And another one is, besides doing rectopexy, you can add mesh. So this actually reduces the recurrence rate in this patients. For perineal repair, there are two options: the Delorme and Antemeyer. So Delorme is for short full thickness prolapse, meaning we only dissect the mucosa when imbricating the muscularis layer. While Altemeyer procedure is for more than 5 cm full thickness rectal prolapse. We do perineal rectosigmoidectomy, in which we also resect a part of the sigmoid colon and do coloanal anastomosis. This can be done by adding levatorplasty to decrease the recurrence rate. Next topic is on fistula in ano. So we know that there are simple and complex fistula. So what's important is, for simple fistula, these are only intersphincteric and low transsphincteric fistula, and the following are complex fistulas. So here are the management depending on the type of fistula. So for submucosal, we can proceed right away with fistulotomy. For intersphincteric fistula, meaning involvement only of the internal anal sphincter, we can proceed with fistulotomy as well. For transsphincteric, there are two types, the low trans and the high transsphincteric. So for low, meaning involvement of one-third of the external anal sphincter, and high, meaning involvement more than one-third of the external anal sphincter. So for less than one-third or low chance, we can do fistulotomy because it is a simple type of fistula. But for high transsphincteric, there are different options. We can do lift. There is can do endorectal advancement flap and other treatment options available on the literature. But in according to our to Schwartz, we only have lift and rectal advancement flap. Other options such as plug, fistula, fibrin plug, the laser, they actually have high recurrence rate. Suprasphincteric fistula have the same management, such as high transsphincteric. So proceed away, again right away with lift or flap, same as well as extrasphincteric fistula. And here is a summary on the treatment options that I said earlier. I will just quickly run through anal carcinoma since this is not usually being covered during exams. So we have for anal cancer, we have intraanal or the anal canal. So it is from the anal verge going up, and perianal meaning anal verge going out 5 cm outside the anal verge. So here are anal canal lesions. Again, so these are visualized, not visualized with gentle traction of the buttocks. And perianal lesions are seen with gentle traction of the buttocks. So this is from the anal verge to 5 cm outside the anal verge. While skin lesions are the ones that are more than 5 cm from the anal verge. So for anal canal cancer, we need to do DRE, evaluate the lymph node, do chest, abdomen, CT scan, anoscopy, HIV testing should be done since most of these patients are HIV positive. So again, for anal canal, the superior border is the anus pubirectalis muscle, around 3 to 5 cm in length, and the inferior border is the anal verge. And we have if the tumor is adenocarcinoma, we actually have to follow the rectal cancer guidelines. For melanoma, the melanoma guidelines. But in this guideline, we need to if the tumor is squamous cell carcinoma, we need to follow this guideline for anal cancer. So again, MRI may be done, but this is to determine should be done. Sorry, this is to determine tumor depth, involvement of the sphincter, presence of perirectal lymph node involvement. And colonoscopy is actually not indicated for squamous cell cancer. So we all heard the Negro protocol. So for anal canal cancer, we can do Negro protocol. So 5-FU with mitomycin with RT. Another option is capecitabine for 5-FU. So for perianal cancer, meaning tumors from the anal verge go up to 5 cm radius. So same workup for anal canal cancer. However, for perianal cancer with that are T1 and 0 well differentiated, we can do local excision with adequate margins and do observation. However, if there's inadequate margin, we can do re-excision or proceed with RT with Negro protocol. But those that are T1 with poorly differentiated or T2 onwards, we can proceed right away with Negro protocol. So for follow-up and surveillance, so we evaluate in 8 to 12 weeks with DRE and anoscopy. And for those with complete remission is the surveillance. So this includes DRE and inguinal node evaluation. And only in patients with recurrence when we do, it is only the time we do APR. Based on the latest guidelines, they actually included adding immunotherapy prior to do APR for local recurrence because in these patients, if they respond with immunotherapy, they can avoid surgery. While those with persistent or progressive diseases, we actually observe them longer, up to 6 months, because in this patient, some would actually regress after 6 months from treatment. And but after 6 months, if there is progression or no remission, that's when we proceed. For progressive disease, that's when we do restaging. So we can do biopsy of the tumor or presence of any ulcers or masses or regrowth. We restage by doing PE, biopsy, CT or PET, MRI as well. And that's when we do APR, or if there's involvement of the groin dissection. So for malignant obstruction, for right-sided obstruction, we can consider right hemicolectomy with primary anastomosis if the ileum has reasonable caliber, if the patient is doing well. But we can do resection with an ileostomy and mucus fistula if the ileum is dilated and edematous, and the mucus fistula will serve as a vent. For right-sided colonic obstruction, other options include leaving the closed distal colon segment in the abdomen, meaning not pulling them out, and creation of a formal colonic mucus fistula in the contralateral abdomen. So creation of an ileocolic anastomosis may be done with proximal diverting ileostomy. So those with obstruction with perforation of the right side, we can do oncologic right hemicolectomy with ileocolic anastomosis, and consider right hemicolectomy with lobotomy, which is the safest approach. And however, this is done in patients with high risk for leak. For left-sided obstruction with non-resectional management, a reverse loop colostomy formation may be done for very frail patient, which we only need to do palliative surgery. Another option is endoluminal stenting, which only serves as a bridge to formal resection. So again, stenting is just a bridge. It's not an end management for obstruction. So for those amenable for resectional surgery, we can do oncologic resection for left-sided colonic obstruction. Options include Hartmann's with encolostomy or subtotal colectomy. For those patients with non-viable proximal colon or those that are very distended proximal colon. We anastomose with ileosigmoid or ileorectal, so we need to consider the condition of the bowel, consider the acute and chronic conditions of the patient. So we do primary anastomosis with proximal fecal diversion with intracolonic lavage. Other option is to do primary anastomosis with or without proximal fecal diversion. For those left-sided with obstruction and perforation, we can do oncologic resection with encolostomy and total abdominal colectomy if the proximal colonic perforation are concerned for colonic viability is a concern. So these are the different signs for obstruction. So clinically, for appendix obstruction, these patients with constipation, diarrhea, tenesmus, weight loss, they have abdominal pain, abdominal distension. Endoscopic obstruction is when the scope is unable to pass the primary lesion. So this is an obvious indicator for pending obstruction. And radiologic on CT scan, so these patients would have fecal loading proximal to the obstruction. So mostly you will see fecal loading proximal to it or air fluid levels. So this is an impending sign of obstruction. So in obstructing rectal cancer naman, so for rectal cancer, you can do loop colostomy or loop ileostomy. So loop colostomy offers effective decompression and may compromise future elective restorative procedure by damaging the marginal blood supply to the left colon if you do left-sided colostomy. While loop ileostomy should be considered if the ileocecal valve is competent, meaning it is competent, you can have closed loop obstruction because of the from the ileostomy and the competent ileocecal valve. When doing self-expanding metallic stent, so the distal end of the stent should be in the extraperitoneal rectum. This is actually not advised because the distal end of the stent should not sit on the anorectal muscular ring because of patients will have tenesmus and there's a very high risk of stent migration. So they actually advise more than 7 cm above the anal verge. So for obstructive rectal cancer, a misplaced stoma can interfere with future reconstructive options, such as a distal transverse or mid-proximal descending loop in the rectal cancer patient. So creation or reversal of transverse or descending colostomy may restrict colon mobility when doing reversal and may also damage the marginal artery. So these are not advised for doing stoma in the distal transverse or in the descending colon. So the best stoma for rectal cancer is the mid or proximal sigmoid colon or the proximal transverse colon when you're using the colon for diversion.
Last slide, last slide.
While an loop ileostomy is usually being used for rectal cancer. A consideration is the closed loop obstruction with a competent ileocecal valve. However, these are usually not seen, and the risk of rehydration in patients with loop ileostomy because these patients would actually have um, electrolyte imbalance or dehydration if there is high output from the ileostomy. Thank you very
Right.
much.
Toot, 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 toot.
Thank you, Dr. Manchin. Uh, there are some questions in the chat box. Maybe we can answer them for the
What?
attendees.
Again.
So first is for polypectomy of a patient who came in for initial screening. What is the cutoff size where endoscopic treatment is considered definitive, sufficient, and just proceed to surveillance? Is some causal invasion based on data? So for patients with polypectomy, I think I discussed earlier. So for example, malignant polyp, no. So if it is pedunculated, we consider the Hadis classification. For sessile polyp, we use the SMI. We mostly use the SMI more than the Kikuchi. So if there is more than 1 mm invasion, we need to do workup kasi for these patients, they are candidate na for surgery. Tapos for size, if we can do ESDMR, so pag 2 cm or less, EMR, the GI usually do EMR, and ESD pag more than 2 centimeter in size. So next is for patients presenting with multiple less than 1 cm with no high-risk features, we do perform prolypectomy on all of them or just representative lesions and determine further management depending on biopsy results. So for less than 1 cm with no high-risk features, we can actually do polypectomy. But if kaya endoscopic mucosal resection, meaning yung we do lifting for EMR, hindi lang yung parang ano mo lang, parang isi-snare mo lang siya polypectomy. So, kasi we need to get a part of the submucosa. That's what's important. So next is for colorectal tumors presenting with obstruction where diversion is warranted if the patient is still a candidate for chemo or RT systemic treatment still considered neoadjuvant if only, yes, kung diversion lang hindi resection, it is still considered neoadjuvant treatment. So after pag na-resect mo na, doon na siya magiging adjuvant treatment. So diversion is only a temporary mean para lang you can proceed right away with your neoadjuvant treatment.
Thank you, Dr. Manchin, for answering those questions very well. I hope the participants were able to get that. And for those